of the seminar. Now, we'll actually be holding the second half as a question and answer panel at the end. So if you have any questions for the speakers, please put those in the chat box at the bottom. If you happen to have any technical issues also, you can post those in the chat box and someone will get back to you via that as soon as possible. Now, it's important to mention that this is going to be recorded for us to send to you, be able to download that and watch it back a little later. So I'd like to introduce to you and welcome Carol Stonham. So Carol is an executive chair of the Primary Care Respiratory Society and senior nurse practitioner of Gloucestershire Clinical Commissioning Group. She's a very prominent figure in asthma care and FeNO. Now Carol's going to go through a few topics surrounding FeNO and how this is applied in asthma diagnostics, management pathways, as well as a few of her personal experiences using FeNO. So I'm now going to hand over to Carol. Over to you.
Lovely, thank you, Damien. So welcome everybody, and thank you for sparing time this evening to listen to what I've got to say about FeNO, and thank you Bedfont for putting on this evening. For those of you that don't know me, as Damien said, I am a primary care nurse based in Gloucestershire. I've worked in primary care for 26 years, so I think I was probably about 10 when I started. And I have stopped working in general practice and I now run a primary care based FeNO clinic and work for the CCG. I'm also one of the South West Respiratory Clinical Network leads and do various roles. And my other role is that I am, as Damien said, the executive chair of the Primary Care Respiratory Society. I've apparently got control of the screen. Oh, I have. How wonderful, it works. So I'm going to go through some information on, oh, I don't think I did that one or that one. This is very interesting. I'm not touching any keys, but things are moving. So I'm going to go through a little bit of information on exhaled nitric oxide and a little bit of background information, and then the practical uses of it in practice, because I think that's what we need to know, is a little bit about what it is and a little bit about what it means. So a little bit about the background, first of all. Amber, I might have to do next slide because I'm pressing keys and nothing is happening. Okay, so I'm sure the majority of you are very familiar with the definition of asthma, but I think it's key to understand what the definition of asthma is. And I think there are some key features that come out in the definition of asthma that we need to be really familiar with when we're thinking about where FeNO fits in. So the first thing is to be very cognizant of the fact that when we're diagnosing asthma, we have to be sure that our patients have got the presence of more than one of the features of breathlessness, wheeze, chest tightness or cough. And it's this variable airflow obstruction that we're looking out for. And then the more recent definitions, and this is from the BTS guidelines, say that both adults and children will have features of airway hyperresponsiveness and this key feature of airway inflammation. And it's the airway inflammation that we're really interested in when we're thinking about FeNO. And then they go on to talk about the subtypes, the different subtypes, the phenotypes and the endotypes that underpin the asthma mechanism. Next slide, please, Amber. So any of you that have undertaken an asthma diploma or are undertaking an asthma diploma will be all too familiar with the complexity of asthma. And if you're not studying at that level, you'll look at this and think, really, do we need to know this detail? And there's arguments as to whether you do or don't, but I think that the key feature that I want you to take away from this diagram is the central red cell there that sits above the sign that says inflammation. And key to the majority of people with asthma is that the thing that drives the inflammation in the majority of people with asthma, not all, but the majority, is the eosinophil. And eosinophilic airway inflammation is key because we know that eosinophilic airway inflammation is very sensitive to the effect of inhaled steroids. And I'm going to come back to that point in a minute. So just keep that in your mind, that this eosinophilic airway inflammation is the key factor in the majority, but not all of the patients with asthma, and it is sensitive to the effect of inhaled steroids. Next slide, please. So what happens in a patient with asthma? So we know that patients with asthma have this genetic predisposition that reacts with something in the environment to give this inflammation. And we know that the inflammation causes airway hyperresponsiveness and reversible airway obstruction. And again, that's a key factor, the reversible airway obstruction. And that's what gives the patient the clinical symptoms. And the clinical symptoms we know the patient complains about are the cough, the wheeze, the shortness of breath. And as I say, these are variable symptoms. Next slide, please. And this diagram is very familiar, and it's one most of us that talk to patients with asthma will use when we talk to our patients. We know that the inflammation that happens in asthma is inflammation that affects the lining of the airways. And this, as I say, this is a really useful diagram, one that I draw a very simplistic version of this. So this is the lining of the airways becomes swollen, becomes inflamed, becomes angry, and narrows the lumen, making it much more difficult. And that's the key feature of asthma. And we also know that patients get bronchospasm, and we know that when the airways are inflamed and angry, they become much more twitchy and much more likely to tend to bronchospasm. So the key features, as I say, is that inflammation, that swelling on the inside of the airways, and then that bronchospasm, that twitchiness that tends to come with it. And I think unless the patients understand that the underlying mechanism is the inflammation, and that's the bit they need to get under control, all they seem to connect their asthma symptoms with is the twitchiness. And a lot of patients that haven't had their symptoms explained to them, that haven't had this explained to them, seem to think that the problem with asthma is the twitchy airways, and that's the bit they need to treat. And that's why we find a lot of our patients tend to be over-reliant on using their salbutamol inhaler, and tend to be under-reliant and under-compliant, adherent, whatever word you want to use, to using their inhaled steroid, which is the one we want them to use. Can we move on to the next slide? So where does exhaled nitric oxide fit into this whole pattern? Well, it's actually a really simple equation. So if you look to the left of the slide, we've got another representation of that whole really complicated cascade. We've got the allergen coming in and hitting the dendritic cell, which causes this whole activation of beta and T cell mediators that release, and there is a spelling mistake there, so if you spotted it, well done. It actually releases mast cells, not master cells. It's a PDF and I cannot correct it, which really frustrates me. And then those eosinophils that kick in, it causes that whole inflammation, and you do get some neutrophils in asthma, but they're not the predominant cell. But the interesting bit is on the other side, and it's the mucous membrane. So when this whole inflammatory cascade is happening with underneath the surface of the lining of the airway, what's happening at the mucous membrane is nitric oxide is being produced. And what we know is that it's coming from that eosinophilic chain of reaction. So if we've got eosinophilic airway inflammation, we've got release of nitric oxide. So it's a fairly simple equation. Next slide, please. And the other thing we know is that the more eosinophilic airway inflammation there is, the more nitric oxide is released in the exhaled breath. So it is quite a simple equation. And I know there are things that can influence the amount of NO that a patient breathes out, and there's quite a lot of controversy around, oh yes, but men produce higher levels than women, so that's going to complicate things. So just think that one through. It's produced from the surface area, from the mucous membrane of the lungs. We know that men have got bigger lungs than women, so they've got more surface area, so therefore they will produce more NO normally. There's also the argument that tall people will produce more than short people. Well, that's because tall people have got bigger lungs than short people, so they've got more surface area. So it's a logical sequence. Therefore, tall men produce more than short women. So it's really not rocket science. And there are other things that will come into play. So if you have patients that have a diet that's high in nitrites, so if you have patients that eat lots of leafy green vegetables, when I practice in an area where we've got an awful lot of vegans, sort of vegan central here almost, it is a question I have to ask, and it is something I have to consider. But it is a consideration. It isn't something that seems to have a huge impact on the results. And some things, so patients that smoke, that will suppress the NO, but also we know that patients that smoke also it has an effect on their spirometry result, but we still do spirometry, we just consider that in the results. So those are things just worth knowing that it's that logical sequencing when you're thinking about the results of exhaled nitric oxide. Next slide, please. So how do we make a diagnosis of asthma? So BTS guidelines tell us the diagnosis of asthma is a clinical one. The absence of consistent gold standard diagnostic criteria means it is not possible to make unequivocal evidence-based recommendations on how to make a diagnosis of asthma. That's helpful, isn't it? So what BTS tell us is that the way BTS have approached diagnosis is to make a pragmatic approach to establishing a diagnosis based on current evidence and the collective experience of the guideline development group. So that's why BTS have come to a different conclusion to NICE. So NICE don't take notice or don't take into account the collective experience of anybody. They take into account evidence-based and cost-effective modelling, which is why BTS and NICE have come up with different ways of making a diagnosis. So that just adds to the slight complication. Next slide, please. So I'm going to focus on BTS. So BTS tell us to take a structured clinical assessment. They tell us to look at the history and the previous records of the patient. We're looking for recurrent episodes of symptoms. We're looking for this key variability. We're looking for the absence of anything else that could account for the diagnosis. We're looking for the recorded wheeze by a healthcare professional, not the one the patient reports, because we know that a patient recorded wheeze can be anything from a deep sighing breath to a stridor to all sorts of strange and wonderful things, but not necessarily wheeze. We're looking for a record of atopy, and we're looking for historic evidence of peak flow, which we might find, or FEV1, which if this patient hasn't got a diagnosis of asthma is unlikely, I think, but we're looking for that in the notes. Next slide, please. And then we're going to assess the probability. So we're going to think about the patient, the history the patient's telling us. We're going to think about the evidence we found about in the notes, and we're going to think about the all of this put together, and we're going to think about, okay, so do we think this patient's got asthma? If we think this is almost definitely without doubt asthma, it looks like asthma, it sounds like asthma, all the evidence points to asthma, we're going to travel down the left-hand side, which is the high probability. We're going to code suspected asthma. We're going to start a trial of treatment. We're going to give them an inhaler with an inhaled steroid at a dose that's appropriate in an inhaler that we've demonstrated and we know they can use. And we're going to send them on their way for 6 to 8 weeks. And then we're going to get them back and we're going to see how they responded. Now, ideally, we will have done spirometry or peak flow at the beginning. We can do a symptom score so that we've got something to measure against. And when we get them back, we're going to see whether or not they're better. If there is a response, so that's on FEV1, on peak flow, on symptom score, we can code that at that point as asthma. We can titrate their dose, check their inhaler technique, start a supported asthma self-management plan with them and do some education, and we know we've got it right. If when we've taken the history and we've gone through all of the information with them, we think, actually, do you know, this absolutely does not sound like asthma, this is something else, then we're going to investigate something else. But it's those patients that sit in the middle that you think, there are some features that really sound like asthma, there are some features that I'm really not sure about, and it leaves you in that dilemma with, it could be asthma, but I'm not sure. That we need to look for some more evidence. So in this central column, if you like, this is where we're looking for some more objective evidence of diagnosis. The objective evidence can be variability, so we can look for reversibility, we can look for peak flow charting, so giving the patient a peak flow to do for 2 weeks, and we're looking for that diurnal variation. If we're feeling extremely brave, or some would say stupid, we could do some challenge testing, but not in primary care, I would suggest. Or we can look for evidence of eosinophilic airway inflammation, or eosinophilic inflammation more generally, or atopy. And lo and behold, if you just press the next button for me, Amber. Here we see FeNO. So FeNO has sat in the BTS guidelines all of this time. And it was only really when NICE came along that we really focused on it. So we can do FeNO to look for specific eosinophilic airway inflammation. We can look at blood eosinophils to look for more generalized eosinophilia, or we can do skin prick testing, or we can do blood IGs to look for more generalised atopy. So if we're looking at blood eosinophils, that's a generalised marker for a localised disease. There are various things that can influence the result. So there are various medications that can influence the result. There are various illnesses that can influence the result. The most common cause of raised eosinophils worldwide is parasitic infection. That's not so much of a problem in this country, but the thing I always think about is, okay, so if, just think about yourself now, when did you last have a full blood count done? Have you got a trend of full blood counts to look at yourself personally if you were presenting with asthma? And would you like to have a full blood count done and to have to go back and wait for the results? Whereas if you did FeNO, it's a localised marker for the localised disease that you're looking for, and the results are almost instantaneous. So to me, it's the sensible thing to do. Then you look at what you've got. Again, you assess your results, you reassess your history, you reassess the information you found in the notes, and then you decide whether or not it looks like suspected asthma. If it does, and the patient isn't overly symptomatic, you can do watchful waiting. If they are symptomatic, which actually I would wonder why they were there if they weren't, you can again start the treatment and get them back and see how they responded. If you look at all that and then you decide actually doesn't look like asthma, then you go across to the looking for something else. So that at first glance looks like a really complicated chart, but if you follow it fairly logically, it does make sense. And I'm not the most logical person in the world, but I think once you get over that initial shock of what is this chart, it is a good chart. Next slide, please. But it's really important to think about the patient in all this. And patients come along with all sorts of ideas, concerns, and expectations. And it's really important to ask the patient what's in their head, because you will never read what's in a patient's head. And some patients will think they've got some terrible, awful disease. They will have gone to Dr. Google and diagnosed themselves with goodness knows what. They may have experience of asthma from other family members. And it's really important to discuss that with your patients, to know what is going on in their head and to think about what the way forward is with that patient. And I think this is a really important step that we sometimes skip. And it's an important step that isn't written down in the guidelines anywhere, but I think is something we need to step back and think about and have that chat with the patients and, you know, say, okay, so what do you think's wrong with you, and how does that sound to you, and what's your experience of this? Because a lot of patients with asthma will have other family members that have asthma that may have had good or bad experiences with their asthma. And actually, to start off with somebody giving them a diagnosis of asthma when they've had really bad experiences with a family member is not a good place to be. And if you don't know that, it can really affect the way forward for that patient. Next slide, please. So if we do FeNO in a patient that has not got a diagnosis, what do those results mean? NICE give us the algorithm that says if it's less than 40, it isn't asthma. If it's more than 40, it can be asthma. But I really like this chart. So this gives you what I call a thinking zone. So you've got a different range for adults and children because, as I say, adults have got bigger lungs than children. So you're going to expect a slightly higher level. In an adult that is presenting without a diagnosis, if their FeNO is less than 25, it doesn't support a diagnosis of asthma, but more importantly, you know that giving them an inhaled steroid is unlikely to help their symptoms. If their FeNO is more than 50 and the patient is symptomatic, then they are likely to benefit from the introduction of an inhaled steroid, and that supports a diagnosis of asthma. A FeNO on its own, with no other context of more than 50, does not mean a patient's got asthma. It is a part of the diagnostic jigsaw, okay? And then that intermediate zone, that 25 to 50, I always call my thinking zone. And I think it's important as clinicians, we have a thinking zone. It depends where in the 25 to 50 zone it is. It depends on how strong you think your probability of asthma is. It depends on the other things that you've gleaned from the patient history and the patient notes and the symptoms and that sort of that overall feeling you're getting. So that gives you the sort of the feeling about, okay, so does that strengthen the case or does that weaken the case? But that's what I always call my thinking zone, and I tell the patients that that's my thinking zone. Okay, next slide. So that's how we can use it in diagnosis, and that's where the emphasis is on diagnosis, and that's where the guidelines tell us. Now, beyond diagnosis, the guidelines tell us that FeNO is useful in management in a specialist setting, but beyond a specialist setting, there isn't the evidence to support it. I am considered a specialist setting, which is great because it means I can use it beyond that, and I find it really useful. But actually, I worked for 12 years in primary care using FeNO, and I think it's just worth thinking about that. So what about patients that present when the symptoms are getting worse? What can you do with FeNO there? Next slide, please. So an ACT is really useful, and I think an ACT should always be done. And I really like ACTs because I think they give you quite an insight into the patient. So it goes through, it's a bit like doing the RCP3 questions. So it gives you a little bit of information about, in the past 4 weeks, how symptomatic have you been during the day, how symptomatic have you been, bless you, how symptomatic have you been at night, how often has your asthma bothered you? And patients will often say, I've been great, it's not bothered me during the day, it's not, you've gone through all those things. And then it'll ask how often they're using their blue inhaler, which is the question that's missing from the RCP3 questions. And then it says, how would you rate your control in the past 4 weeks? And sometimes that doesn't marry up, and it gives you an insight into the patient's understanding of how their asthma control could be. And it gives you an insight into how their rescue use marries up with their symptom use. And sometimes there's a real mismatch there. So it's quite an interesting thing to do with patients. Next slide, please. So I'm going to introduce you to who I wish was one of my patients. At this point, disclaimer, I don't think Hugh Jackman has asthma, but I think it's much nicer to look at than fake patient. So Hugh Jackman, this patient is anonymous Hugh. I have to say at this point, I did private message Hugh Jackman once on Twitter to tell him I was using his picture, and I did get a reply, which was quite nice. So Hugh comes into surgery. He's had asthma since he's 47. He's had asthma since he was 27. He uses inhaled beclomethasone 2 puffs twice a day. He uses an air chamber most of the time. He's a non-smoker. He has been increasingly symptomatic over the last 6 weeks. He is occasionally waking up at night because of his asthma. He's needing to use his rescue inhaler most days. But today he's come for a routine appointment. So this is not an emergency situation. This is the information you've found just because he's come for a routine appointment. Next slide, please. So what does BTS tell us? BTS tells us to add in a long-acting beta-2 agonist, to review, and if it's effective, to continue it. If it's ineffective, to stop it and increase the inhaled steroid. If it's partially effective, continue it and increase the inhaled steroid. And then review again. And if still not controlled, consider other therapies like montelukast or theophylline. So montelukast and theophylline in the same sentence feels very wrong to me. That just feels not quite right. But it does feel a little bit like the shoulder and weather forecasting stone, doesn't it? It just feels like a bit, try this, try this, try this. You never know what's going to work. And this asking the patient whether they're better or not also is not very objective. So I always find that there are a couple of issues there. If you ask a patient if what you've done makes them feel better, they generally say, at the very least, a bit, because you're really nice and you've done your best. So they're going to say, yeah, you've made me feel a bit better, even if you haven't. But if you add in a long-acting beta-2 agonist, the very least you're going to do is replace the short-acting beta-2 agonist with a long-acting beta-2 agonist. So they may perceive they feel better because they're not needing to use their rescue as much. So that leaves you in a slightly difficult dilemma. Are they better or not? So is there a more objective way to do this? Is there a more objective way to guide your treatment decision? Next slide, please. So you can think about how you do this with the patient. You can take a history from the patient and ask them, okay, so when this has happened before, if this has happened before, what's worked? So when you've had symptoms and you needed to increase your treatment, what's worked, what hasn't worked? If you've exacerbated, is this your usual pattern? Does this lead up to anything worse? Or is this, does it usually go away on its own? You need to gather information. And I know we're always told open questions, but sometimes there is a place for closed questions where you want to actually get the right responses to some things. bear in mind the patients with asthma are the experts in their disease quite often because they live with it all of the time, and you are getting a very small snapshot into what they're living with. So ask them the questions, take the opportunity to say to them, okay, so is this different? Has this happened before? Is this usual for you? What was it that sparked this off? Can you remember? So take the opportunity to really talk to your patients. Next slide, please. They're usually quite nice, most of them. So you're going to do any tests. So if you do spirometry, would it be useful? If you do FeNO, would it be useful? Next slide, please. So back to this chart I showed you at the beginning. So as I say, we know that we've got environmental factors that cause airway inflammation, that cause airway hyperresponsiveness, that cause airway obstruction, that cause clinical symptoms. And we can measure airway obstruction because we can do spirometry. We can measure clinical symptoms because we could do questionnaires and we can ask, we can do an ACT, for example. We can measure airway hyperresponsiveness because we can challenge test patients, although we don't. But we don't measure airway inflammation. And that's key to what's going on here. So to me, it makes sense to measure airway inflammation. Next slide, please. And that's the bit I think we're missing from this whole jigsaw. Next slide. So as I say, it is this very simple equation of the airway inflammation that's going on underneath the surface is hitting the mucous membrane and causing release of nitric oxide, which the patient blows out every time they breathe. So if we capture that in a very simple way, it tells us whether the airways are inflamed or whether it's not the airways that are inflamed, it's bronchospasm causing the problem. So that should guide our treatment decisions. Next slide. So back to Hugh. So we do spirometry and we're not surprised that it's normal. So his FEV1 is 90% predicted, his ratio is 78%, so that's a normal result. And that's often what we find when the patient presents and actually at that moment is feeling okay. He's got good inhaler technique, he's Hugh, he's gonna have good inhaler technique. He's got good adherence, he's got no new triggers, so there's nothing that set this off. But he does give a good history of recurrent episodes of a prolonged cough with sputum. And this particularly happens after he gets an upper respiratory tract infection, although this time it wasn't an upper respiratory tract infection that set him off. It just was something that just built up and built up and built up over a period of time. Next slide, please. And his FeNO is 72. So if we followed the BTS guidelines, we would give him a LABA, blind to the fact that his airways are actually very inflamed. But knowing that his airways are inflamed would change our practice and would make us do something different. It would make us tackle the airway inflammation. Now there is a clue there because that cough with sputum and those recurrent episodes puts him into that phenotype of patients that does have episodes of increased inflammation causing that cough and that sputum. But it's not always as clear cut as that. Next slide, please. So when we have patients that have got an established diagnosis and they present and we do FeNO, where do the cut-off markers lie? So we know that if we do FeNO and a patient's FeNO is, so we're talking adults, is less than 25, we know that increasing a steroid is not going to make any difference. It is not going to target any symptoms. So adding in a LABA is exactly the thing to do. That is precisely the thing to do. If the FeNO is over 50, there are two things to do here. So it might be an adherence problem. It might be that they've got an inhaled steroid, but they're just not taking it, or their inhaler technique is so shockingly poor, it's not going in. So it is around looking at inhaler technique before you do anything else, as with all of these things. Talking about adherence, because often that's what's the problem here. And if neither of those things are the problem, then looking at actually the dose that you're giving the patient. And then that intermediate section between 25 and 50, again, is it inhaler technique? Is it adherence? Whereabouts are they falling between 25 and 50? Is it more on the inflamed side, or is it quite low down and actually you've got that weighing up to do between, do I want to add in a LABA or do I want to increase the steroid component of the patient's treatment? But it guides where you're going with the treatment. Next slide, please. So this is about personalised care. This is about getting it right for the person in front of you. This isn't about simply blindly following the guidelines. They are guidelines, not tramlines, and we should be getting it right for our individual patient. Next slide, please. And this is a really interesting study. So it's a small study. It was only 50 patients and it's done in America, but it was in an allergy clinic. And bearing in mind, American healthcare is paid for healthcare. This is an allergy clinic that specialises in nothing but allergy. So these are all patients that go in with asthma. And what they did was they saw the patients, they took a history. They were patients with asthma that were increasingly symptomatic, and they made their treatment decision blind with no FeNO. They then measured FeNO, and in only 50% of the cases did they stick by what they decided to do in the first place. Once they'd done FeNO, the FeNO changed their treatment decision. And this is an allergy clinic that specialises in nothing else, in paid for healthcare. So I just found that really interesting, that actually this is somewhere where they do nothing else but that, where they should be really good at it, and where it's paid for healthcare, so you'd hope they get it right, because, you know, there are financial consequences to the patient. But it was just an interesting study that 50 patients, you know, there's probably no p-value there, but it was interesting. Next slide, please. So this was a patient of mine. So Poppy was a patient of mine. So she's 17 years old. She was new to the practice. She'd had asthma all of her life. Since she joined the practice, her symptoms have been increasing. So I practiced in a very affluent area. So it's Minchinhampton, which is where Princess Anne lives. That sort of patient population. She went to a very exclusive private school. She had her own horse. She played hockey, and she was running into problems. So she was prescribed FeNO, 100 micrograms 2+ twice daily. Her prescribing history backed that up. She described her asthma as usually well controlled, but she'd become much more symptomatic since she'd moved to our area. She had stopped playing hockey. She was having to pay somebody to groom her horse, which was upsetting her mum because it was costing money. And when I said to her, how's your asthma? And she said, well, it's usually all right, but she said, it's really bad at the moment. I have to use my blue inhaler all the time. Next slide, please. So we went through the usual things, and BTS tells us quite clearly, before initiating new therapy, practitioners should check compliance with existing therapy. So the prescribing information was exactly right. Her inhaler technique was really good, and eliminate new triggers. So she just moved. So I thought that was probably my best bet. Next slide, please. So I thought I was dealing with a trigger problem. Did a FeNO, and her FeNO was 124, and she was 5'2", and she weighed probably about 8 stone, so she was very, very little and quite slight. And that was quite a surprise to me. And when I said, Poppy, I don't understand this, you're on quite a reasonable dose of inhaled steroid for your size, your lungs are really, really, and I always explain, do you know what asthma is? And I draw the diagrams with circles. And when I said, this is telling me your lungs are really inflamed, I do not understand why your lungs are inflamed when you're on on a reasonable dose of inhaled steroid, and your inhaler technique is really good, and I can't figure out what's kicking that off. The problem was, next slide, please. She wasn't taking it. So I'd checked the prescription records, which were absolutely as they should be. I'd asked the patient, and she told me she was taking a medication. And it was only when I could challenge her with this information that she told me that she didn't take the medication because every time she took it, it made her cough. And because it made her cough, she'd abandoned it, and she'd abandoned it 4 years previously. But she continued to collect her inhalers because her dad was asthmatic, and she gave the inhalers to her dad because her dad, even though they lived in a very, very expensive house and she went to an expensive private school, her dad didn't want to pay for his inhalers. So she'd continued to collect her inhalers and give them to dad. So we got to grips with what the problem was, changed the inhaled steroid, found one that she could use, found one that she liked, explained what the problem was, really got her on board with it, having used FeNO. Next slide, please. And this is a study that shows that FeNO is a really good tool for picking up non-adherence. And you can see on the left that patients, whatever their adherence is, their FEV1 will remain the same. But on the right, the bars there show that the different levels of adherence are very clearly picked up using FeNO. And there was a really good study where Liam Heaney he did FeNO suppression first of all, so he sent a research fellow around to people's houses to watch them do their inhale steroid and do their FeNO, and then left them with the machine explaining what they were doing, and you could tell the patients that stopped using their inhaled steroid because their FeNO immediately started to climb. So it's a really good tool for adherence. And one of the reasons for referral to my clinic is for patients that the clinician knows is non-adherent or suspects is non-adherent, but doesn't have the time or the capability to have that conversation with the patient. So they'll refer them to my clinic, and I have that conversation with them. Next slide, please. And this is what this is all about. It's not being accusatory. It's not about being difficult. It's about working in partnership with the patient. It's about opening the dialogue, and it's about being able to have a bit noisy. Being able to have a conversation and work out why somebody's not taking their inhaler, and explain to them the importance and what they can achieve if you work with them and you both get it right. And when they come back and they feel much better, it enlightens them so much that they're prepared to work with that. Next slide, please. So what Poppy had been doing is she'd been using just her blue inhaler every day, a couple of times a day. She'd never used her inhaled steroid, but nobody had asked her. So in a previous practice, when she was asked, how's your asthma? And she'd said, it's fine, thanks. They checked her inhaler technique and it was pretty good. They hadn't looked at how much salbutamol she was using. So she automatically got a brown and a blue every month. And she went through a brown and a blue every month, but nobody checked. And nobody asked those probing questions around, how is your asthma really? It was very much the tick box, how's your asthma? Good. How's your inhaler technique? Good. So I was impressed they checked her inhaler technique, but it never went any further than that. So you have to be quite specific about what it is you want to know about a patient's control of their asthma and around their rescue use and all of those other things. And I usually start the conversation with, has anybody explained to you what asthma is and what your inhalers do? And the answer I would say I get 99% of the time is either nobody's explained or somebody explains and I've forgotten. So that's always my starting point with asthma. Next slide, please. So Poppy came back to see me 6 weeks later, and her FeNO had gone from 124, I think I said it was, down to 44. It drops that quickly. If only my weight would do the same, I would be delighted. But more importantly, she felt better. She could then look back and see how bad things really were. And she was back to feeling her normal self. So she was back to playing hockey. She was back not only to grooming her horse, but to riding it again. And we had a happy Poppy. We had a happy mum because she wasn't paying anybody. We had a not so happy dad because then he had to make an appointment to come in and see me as well to sort his asthma out because Poppy was using her inhaled steroid. You win some, you lose some. But things change really quickly with FeNO, and you can make a difference really quickly, and you can onboard people really quickly. The reduction took 6 weeks. So that was a reduction from 124 to 44 in 6 weeks. It drops really quickly. Next slide, please. So what else can you use it for? So the other group that are sometimes quite difficult to get on board, the patients you want to step down. So we step them up. We're really good at stepping them up. We're really not very good at stepping them back down again. And it's not knowing which bit to step down. So the thing we have concerns about are patients that are on high dose steroids. And you need to review your patients regularly to be able to step them down, because if you don't see them, you're never going to do it. So it's being aware of those patients that are on higher dose step down, higher dose steroids. We need to, what we're looking to do is to maintain them on the lowest dose possible of inhaled steroids that controls their disease, because we don't want to sort of unbalance the scales, if you like. And the guidelines don't give us much detail on this. So we know it should be a slow reduction in inhaled steroids, but we know we first do no harm. So the last BTS guidelines only quoted one paper on this, and I know one of the authors was called Twaddle, and I don't know why I remember that. I think it's obvious why I do. But there's so little information on this. So sometimes to convince a patient to reduce their dose when you've got them under good control and they feel confident on that is difficult. So that's one of the other referral criteria into my clinic, is if you've got a patient you want to step down and you want to step that patient down. Next slide, please. But it is about planning in advance. So you can't just step a patient down all over the place. And I think the first thing you need to do is a little bit of horizon scanning. So if you are intending to step a patient down, you need to think about what's in the next few months. So I would never step a patient down that gets hay fever going into the hay fever season, or that has a trigger of cold air and infection during the winter season. I would never step a patient down a couple of months or within 6 weeks of them getting married, for example, because you don't really want them poorly for a wedding. Or exams, big events, don't do it then. Think about a time when things look pretty stable on the horizon, you're not just going into anything that could trigger them, and things are pretty safe. So you stand a good chance of keeping them really well. So you get them on board, you make sure they're well, and then look back as well and make sure they have been well for about 3 months. So they need to be asymptomatic for at least 3 months before you consider reducing it. And they need to be going into a period of stability before you do that. So those are your 2 criteria that you're going to think about before you do anything else. And then FeNO can be used as a tool to see how the land lies at that moment in time. Can we go to the next slide? So this is the guidance for patients that are stable, that you think about stepping inhaled steroids down. So if their FeNO is less than 25 and they're well, and they've been well for 3 months and they're not going into a difficult season, then you can think about it. So you do it with all your usual safety netting, and you think about, okay, so I'm going to step it down. And generally speaking, I tend to be cautious, but not as cautious as the guidelines. So the guidelines tend to say you can reduce it by 25 to 50% every 3 months. Take forever to get there. So I tend to, if they're on 2 puffs twice a day, I tend to say 2 puffs at night and 1 puff in the morning for probably about 3 weeks, and then 1 and 1, and see how you go. And if any stage of symptoms start to come back, just go back to your 2 puffs twice a day. So I have a very non-technical approach to it. If they are in the high zone, so first of all, I would be readjusting their education. So if they've just told me that they are asymptomatic and they have been for 3 months, yeah, I can see that their airways are inflamed. I would be asking about, are you sure you're really well because your airways are inflamed? Now, some patients can be asymptomatic with airway inflammation, but it's unusual. So I'd be going through their education. I would definitely not be stepping them down. I would be checking their inhaler technique and their compliance, and I would not think about reducing if they're over 50. If they're in that intermediate section, again, I wouldn't be stepping them down. I would be thinking about what's going on with them. I would be checking their inhaler technique and their compliance, and I would watch them for quite a long time before I considered stepping them down. But that group of 25 or below, if they've been stable for 3 months and they're going into a stable period, really good to try and step them down. Next slide, please. And this is why. So this is a study that only looked at a small number of children, but it was kids, and kids can be a bit unstable. So this was 40 children that were stepped down using FeNO as a guide to step them down, to look at a predictor for risk of relapse. If we go on to the next slide. So this shows you what happened to those children. So those children, you can see, so they had baselines, they had good baselines, 14 and 10, and then they were checked again at 2 and 4 weeks. So those that were going to relapse, you can see really quickly went back up again. So within 2 weeks, they were back up to 35, and 4 weeks, 40. And those that weren't going to relapse stayed around the same level. So what you can do with these patients is you can do the baseline, and if their baseline is nice and stable, you can reduce their inhaled steroid and then see them a couple of weeks after they've reduced their inhaled steroid. And if they remain okay, then that's okay. You can leave them a bit longer, or you can reduce it and do it again. If their baseline has started to creep up, then before they become unwell, you can usually pick up that you really shouldn't have done that, and you can put their dose back up again. So it's quite a nice way of monitoring them before they run into problems. So a lot of patients are quite happy just to try and reduce the dose, but you do sometimes have those patients that just won't do it, and they can be on quite high doses of steroids. So I would use this for those patients that are on fairly high doses that you want to step down a bit. Okay, next slide, please. So this is the clinic that I've been running over the last couple of years. So it's been on a different funding models, but the last year it's been on an invest to save business case based on the figures from the previous year. So that's been showing that the savings made to the prescribing budget around reducing prescribing for inappropriate prescribing and step down, and for not diagnosing asthma in those that didn't have asthma, has been enough to fund the business case for a year. So it's not saved money, but it hasn't cost anything. It's been cost neutral. It's direct primary care referral, so any primary care clinician can refer to me. And the criteria, as I say, is for diagnosis using intermediate probability of asthma using BTS guidelines, step-up advice, step-down advice, patients that need education. So sometimes, you know, those patients that just don't get it, they can, because the appointments are slightly longer than you would get in primary care, they could be referred to me. Patients with adherence issues and patients with difficult but not severe asthma, they are different. So difficult asthma tends to be those patients with education and adherence issues. And I'll see anybody from age 5 and up. Under 5 can't tend to do the test. And those are the 2 sites that I use. So that's Stroud and Dursley, 2 community hospitals that I use. Next slide. And I see patients from 19 practices. So it's 92,000 patients in total. So things have changed recently. My clinic was suspended through the start of COVID, and we were just about to recommission, which was unfortunate timing. So we're still waiting to recommission. COVID has changed the way we do things, and I think we will be in a completely different era as we come out of the other side. Next slide, please. One of the challenges has been around diagnosis, and for quite a long period of time, we were in that, what's an AGP, what's an aerosol generation procedure, and what's not. We've come out the other side now in that we know that FeNO is not considered aerosol generating because it is not, it's a low effort procedure, so it doesn't induce cough. The filters are the right filters to trap virus. The machines do need cleaning down between patients, but then we should be doing that with everything. Spirometry, as you know, we can stand back up in a limited safe capacity in primary care if you've got the ability to do that, but it's still a bit complicated. Primary Care Respiratory Society have put out a really good paper around diagnosing and managing asthma and COPD in the COVID era to give you alternatives to how you diagnose. But it is complicated, and it's that, are we going to be moving to the diagnostic hub model? But if we use a diagnostic hub model, we will lose the ability with FeNO to manage patients as well. So the management side of it will be lost, and we're discussing that certainly in Gloucestershire. Next slide, please. I think the important thing in all this is not to lose the perspective and the voice of the patient. I don't have asthma, I don't have any, touch wood, but I can't find any. I don't have asthma and I don't have any asthma in my family, but I think these are very pertinent comments and very pertinent quotes, particularly the left-hand side from a 5-year-old. When I have an asthma attack, I feel like a fish with no water. It must be the scariest thing in the world. We know that asthma still has huge symptom burden and patients still die from asthma, and we still haven't got that right. It still feels like there's still a bit of an inequity between asthma and COPD, in that there's still quite a lot of focus on COPD because it costs the NHS more money. And I think we still need to get the focus slightly more equal between the 2 diseases, because we're supposed to be doing, we're supposed to be focusing on equity for patient journeys. And I think we still need to do a little bit more work on that. Next slide, please. That was all I had to say. That's quite a lot, as is usual for me. I do apologise. So I'd like to hand over to Hannah, who is going to pick up the questions, and we've got a couple of other panel members to answer the more technical things about the machines and the costings and the likes. Thank you.
Carol, thank you very much. I am actually going to hand straight back to Damien because my internet is incredibly unstable. So
yeah, thanks Hannah. So yeah, apologies guys, we are encountering 1 or 2 technical problems. Hannah Vince-Drew is actually our clinical lead at Bedfont Scientific, so if we do have a little trouble, she might be able to input in the chat box at the bottom. But yeah, firstly, Carol, thank you, very, very informative as always. So we'll have Carol, Hannah, to answer questions, as well as myself from Bedfont Scientific, and we've also got Richard Haynes, who works for Intermedical, and he's the primary care manager who distribute Bedfont Scientific's No Breath. Now they are coming in thick and fast, so if I happen to miss one out, apologies. So we've got a question from Christine, and that is, will rhinitis impact on the FeNO score? Carol, I think that one's for you, maybe?
Yeah, so it can do. So patients with rhinitis do can push the FeNO up. It depends on the way they sort of shut off the back of their throat when they blow sometimes. So if a patient's got a high FeNO, it is worth asking about their nose, but that's no bad thing, because I think the other thing we're not really very good at in patients with asthma is asking about their nose. So it does prompt you to ask about that. You can actually do nasal FeNO with some of the machines, but I don't know the value of that unless you're I was going to say nasologist, that's not a word, unless you're an ENT type person. So if it's one of the things that we know pushes FeNO up slightly, again, it isn't something I've ever found a massive issue in interpreting the results. It's something that I've actually found quite useful, because often, as I say, you sort of go through your mental tick list when you say, you know, if you've been eating leafy green veg, are you a smoker, how's your nose? And then it prompts you onto that next conversation with the patient. If they say, oh, my nose is a bit blocked or snotty, it prompts you onto that next conversation within your clinical consultation. But you do sometimes have to take that into account, but it's not massive, it really isn't.
Okay, lovely, thank you, Carol. Now we've got a question from Sophie. NICE CKS advised to add Montelukast before LABAE. Do you agree with this? I'm hoping those acronyms make a little bit more sense.
They do, yeah. So that's NICE. So if you look at NICE rather than BTS, so BTS say add in a LABA, NICE say add in Montelukast. So that's done, as I said. So BTS will look at the evidence and the opinion of the guideline group. NICE will look at the evidence and the cost effectiveness, which is why there's a difference in decision making there. I would look at the patient in front of me, and I would use either. So I would be looking at whether or not the patient's got other symptoms. I would be considering the FeNO. So if the FeNO is high, I might add in Montelukast, or I might add in a little bit more inhaled steroid. If the patient's got rhinitis, I would probably go for Montelukast rather than a LABA. So our formulary is, I sit on our formulary group, so I tend to stick my heel in and say we need to offer both. So they sit equally on our formulary. PCRS have gone for a value-based approach. So PCRS are currently supporting Montelukast because it's the value-based approach. But I say what you need to do is look at the patient in front of you, ask questions around what you think would be best for the patient in front of you, and bear in mind NICE and BTS are both guidelines, and you do what's right for the individual patient in front of you. Okay, lovely, thank you. There's a question here from Sandra Fugel, and she actually added another question that I'll get to once I've read this. Are there any plans to roll out diagnostic hubs across the UK? That was her first question. She then went on to ask, how beneficial do you think the diagnostic hubs will be in the long term compared to the standard asthma management and care already provided? So there are two lots of diagnostic hubs being rolled out at the moment, so things have been slightly confusing. So there are what are being called community diagnostic hubs, which are from the Richards Review, which are complex diagnostic hubs for all sorts of conditions. So they'll include imaging, CT scans, they'll be for suspected cancer diagnosis, for cardiology, and will include spirometry and FeNO as part of that. So they're your complex pathways, and they should be set up at around 3 per million. The funding isn't quite as much as was expected. In fact, it's quite a lot less than was expected, so I don't think they will be 3 per million. So those are your complex diagnostic hubs. The other hubs that I'm actually leading the NHSE work on are the local diagnostic hubs for breathlessness. So those are for your patients that, when they've seen the initial primary care practitioner, and it sounds from the history like it almost is going to be asthma or COPD, those are the hubs that will be set up at PCN level, and will most likely have spirometry with reversibility, FeNO and carbon monoxide monitoring, and will be looking to prove or disprove a diagnosis of asthma or COPD, and could feed into your respiratory, will have contact with your respiratory integrated team or consultant, and if the diagnosis isn't as you thought, could then go on into your complex hub. They will be massively beneficial, because the idea is, currently we know from the National Asthma and COPD audit that diagnosis isn't being made as well as it should and isn't being supported by the right tests. And if we've got people that are really, really competent and trained at making a diagnosis within the hub, then that's the best place for the patient to have the test done. And it's like a one-stop shop, so they get it all done in one go instead of dotting around the system. So it should improve patient care. There was a minor hiccup in the road with NHS England this week that I'm really hoping to iron out before it goes too much further.
Okay, brilliant. Thank you. So we've got another one here from Emma Ray, and this is, have you got any cost comparisons for diagnostic tests, please, to build a case to purchase a FeNO machine in primary care? For example, spirometry versus FeNO. And actually, I think Richard at Intermedical, this one might be a good one for you.
Yeah, well, a bit tricky really when you're comparing something like spirometry to FeNO. The costs of FeNO are more expensive for a diagnostic test than spirometry peak flow meters. So it's a tricky one to answer without going through the whole shaboogle, if you like. So it is more expensive.
It's a very unlikely comparison to say spirometry versus FeNO, isn't it? Would you say?
Yeah, absolutely. It's not something you'd normally compare. And yeah, if you're looking at cost that way, it's not an easy thing to do.
Carol, you might be able to have some input. Would it be advised to not look at them as two separate, but to perhaps maybe get them working together? Or
yeah. So the way I see them is they're different parts of the jigsaw that make a diagnosis, and the thing I always find with an asthma diagnosis is quite often when you do spirometry on a patient that you think has asthma, because the day they present, they're actually pretty well. So you tend to get normal asthma results, normal spirometry results. So that doesn't really clarify anything. Whereas if a patient feels well on the day they present, that background inflammation is still sitting there. So their FeNO still tends to be raised. So FeNO, regardless of the day that they present, whether it's a symptomatic day or an asymptomatic day, you still get that raised result that supports the diagnosis of asthma. So they are different parts of the jigsaw. Personally, I find FeNO more use than spirometry in diagnosing asthma. And I think the feedback from the pilot sites when they did the NICE, when they were looking at the NICE guidelines, when they were putting the NICE guidelines together, was the same, in that when they fed back to say what was useful, was FeNO useful, was spirometry useful, spirometry wasn't helpful because it was always normal, whereas FeNO was helpful because they found that the eosinophilic inflammation was there, but the spirometry was just normal.
Okay, grand. We got a question here from Claire Wright, and that is, I have patients FeNO 70 to 80 and no symptoms at all. I've got to admit, Carol, we tend to have a FeNO test every morning at Bedfont, and whether or not I have a morning beverage can sometimes affect my FeNO. So I don't know, maybe you could elaborate a little more. I know you mentioned something at the beginning. Yeah,
so a raised FeNO is not a diagnosis of asthma. You've got to have those other features. So you've got to have symptoms, you've got to have variability, you've got to have those things that sit in the history. So a raised FeNO is an indication that a patient has eosinophilic airway inflammation. So it's making sure it's not those other things, making sure that they've not eaten a load of kale or spinach the day before they've had or just before the test, making sure that they've not done vigorous exercise because that can have an effect on their FeNO. So it's all those other things. But there are a few people that do just sit with a high FeNO. So when the original piece of research that I did with Mike Thomas was about 12 years ago, and it was looking at the feasibility of using FeNO in a primary care setting. And we had one person in our study, and she was only, I think she was 14 at the time, and her FeNO was massive. It was like 300 all the way through the studies. And she had asthma. She was well controlled. She used her inhalers, and all the way through, it was always massively, massively high, and it never changed. And to the degree we were tempted to throw her out of the study because she kept messing our figures up. And I saw her probably when she was 25, just as a routine. And I said, "Oh, Hannah, while you're here, let's just check your FeNO and see what it is." 300. So some people just sit outside of the normal range. And some people, I mean, mine's all interesting. I don't have asthma, as I say, mine's always 35. So there are some people, you don't treat the FeNO you treat the whole person. So you have to do it in the context of what you're treating.
Lovely, thank you, thank you. We've got a question here from Carlos Olivia, and this is, are there any studies on course about COVID-19 and its relationship with FeNO? Hannah, if you're around, maybe could you elaborate on, would you have any input on that one?
Yeah, so currently we are working with a research group out in South America, in Brazil, who's looking potentially at a relationship between FeNO and COVID-19. That is currently still ongoing. They're still recruiting. They're still gathering data. So I can't really comment on what the outcomes of that is currently, but it is something that is currently being investigated and looked into.
Okay, brilliant, thank you, thank you. We've got another one here. This one is to Carol. It's, hi Carol, I've had a few kids in my diagnostic clinic with plus BDR but low FeNO, which surprises me. Could you comment on that, please?
Yeah, so most but not all asthma is eosinophil driven. So most but not all. So there are some patients that don't have an underlying inflammation but just have twitchy airways. So that is that different phenotypes and different endotypes. And that is a really difficult one because we routinely say that all of our patients should be on an inhaled steroid. And that makes you go, oh, should they? Because actually, what are you targeting with your inhaled steroid? And it does put you in a really difficult position because, you know, you're thinking, this patient's obviously got twitchy airways and this patient's obviously got something going on there, but what am I doing with an inhaled steroid? And it is really difficult because you do question, second guess what you're treating.
Okay, great, thank you. Again, we've got another question from Sandra Fugel. How much does FeNO cost to implement? I think Richard, that one would be one for yourself.
Sure, okay. So the cost of the equipment, we're currently running an offer for the equipment on the back of this presentation. So we're doing the device with 100 mouthpieces for 1,795 plus VAT. Now, the normal price for that would be nearer the £3,000 mark, so it's a pretty good offer. And I think we're going to mail out the offer to everybody that's attended the presentation anyway. So that would be the initial cost to set up a FeNO clinic. And then ongoing running costs are just an annual service for that for £150 a year. So it's expensive, but it's no more expensive than an ECG machine or anything, you know, like that. So it's worth looking at.
Okay, grand, lovely, thank you. We've got a question from Crispin Fisher. What is the guidance about using FeNO during the COVID pandemic in terms of infection control and prevention? So actually, I think, Carol, you mentioned something a little get my words out, a little earlier. A FeNO test is non-aerosol generating.
Yeah. So originally we weren't sure, so we were told don't do any of the lung function tests, any breathing tests, nothing. But because it's low effort, so it doesn't induce cough, or it shouldn't if you're doing it properly, then it's considered a very low, nothing's no risk. So that's the first thing is nothing's no risk. So as long as you've done your COVID check with your patient and they're not showing any symptoms, then it's considered very low risk. So it's safe to do. The other thing is that the mouthpieces have got all of the antiviral filters in them. So remember, you need a new mouthpiece for every patient, and you can't hold on to your mouthpiece and use the same mouthpiece the week later that the patient comes back. So you use it and you bin it safely in your clinical waste, and the machine needs wiping over as you should do between every patient anyway. So now we know that it is absolutely safe we know it is safe to do that, and that's from Andy Menzies-Gow, who's the National Clinical Director for Respiratory, has been promoting that message. And it's come out from ARTP. It's in the ARTP guidance from the end of October.
Fantastic, fantastic. And actually, the No Breath has what we call stereotype technology, which massively increases infection control. There was also another question that relates to that. This is from Raul Good. It's interesting. I'm here for only one thing. How do you do a FeNO test? So I might even be able to, I can answer this one myself. It actually is incredibly simple. It's a simple exhalation of 10 seconds for a child. This is relating to Bedfont's FeNO device, and 12 seconds for an adult. As simple as that.
Mine's sat up there. It's literally got a nice graphic on it. It's got a car going along a road, and you just blow and you make sure you keep the car on the road for 12 seconds. And then you wait, and it just tells you the result on the screen. They're really easy. I mean, everybody worries about being trained to perform FeNO. That honestly is easy. The bit I am concerned that people get the training for is to fit it into your asthma training and your asthma pathway, so that when you've got that result, doing the test is really easy. Once you've got that result, you know what to do with it in the context of the patient in front of you.
Brilliant, thank you. Can I just revert back to one more? Sorry, there was one that I thought was quite interesting. If a patient starts taking... this is from Caroline Taylor. If a patient starts taking intercorticosteroid, how long does it take to reduce FeNO? She says an approximation of a month, maybe. Carol, maybe you can...
Yeah, you see a big drop in a month. So if you have, as I say, with Poppy that I saw, that was 6 weeks and it dropped really quick. It dropped from 120 something down to 40 something. So if you have a patient that is newly diagnosed, or particularly patients that are non-compliant, if you get them to if I see a patient that is non-compliant, I would talk to them about what asthma is, about the importance of taking their inhaler, about what it does, and then I usually bargain with them a little bit and say, just humour me. Look, your asthma, your airways are really inflamed. Just humour me. Just take it twice a day for a month, and I promise you'll feel better. And they'll usually just say, oh, just for a month. Okay, then. So I'll see them in a month, get them back in a month, and then when they come in, I say, how do you feel? And they say, what's my FeNO? And I say, no. How do you feel? And they say, no, what's my FeNO? And then we have like 2 minutes of that. And then when I do their FeNO, which has dropped massively, then I say, how do you feel? And they say, actually, do you know what? I feel really good. So a month is enough to drop their FeNO considerably and to make them feel better, to get them on board. But a month's not enough to get full benefit from the inhaled steroid. But a month's enough to get their FeNO down and to make enough improvement to get them on board to do it for a bit longer. And then I usually see them for a second month, by which time I'd expect them to be normal FeNO and pretty much asymptomatic.
Okay, grand, thank you. We've got another question actually from Raul Good. He says, asymptomatic, high FeNO, how do we monitor? So that one is a bit brief.
Yeah, so asymptomatic high FeNO, I would be asking questions why. So I would be checking the things that can cause a high FeNO that isn't asthma. So I'd be talking about rhinitis. So I'd be making sure they're truly asymptomatic. So are you sure you're not getting daytime symptoms, nighttime symptoms? How often are you using your rescue? Those types of things. And you're not treating the FeNO, you're treating the patient. I'd then be asking about allergic rhinitis, because it may be the rhinitis that's pushing the FeNO up, not the asthma. So it may be worth targeting the rhinitis. And then it's probably worth checking it again in 6 weeks just to see what's going on with that patient, because it may be that actually, if you're already doing a point in time, so if you haven't done it before, if you just do it as a one-off, they may be rising, they may be heading towards an exacerbation. So I would check them again in a month, but tell them to ring me sooner if they start to feel more unwell. Or it may be falling. So if you're just doing a one-off test, you're just sort of sticking a pin in a board. And as I say, maybe they're on the way up or maybe they're on the way down. And it's worth just doing another one to see if they're level at that or if they're going up or down.
Okay, grand. There is one more. I'll make this the last one and then you can settle down for the evening. Again, this is another one from Claire Wright. Increase into LABA. What if patient is very sensitive to FOST air and causing severe palpitations and arrhythmia. Oh, I'm not going to pronounce that one.
Yeah, so yeah, it's difficult. So if it's that weighing off. So if they are if they're getting lots of palpitations, were they getting palpitations when they were using lots and lots of short-acting beta-2 agonist, or is it the Foster that's doing it? So if it's the Foster that's doing it, if it's the formoterol that's doing it, then it might be worth trying one of the other ones. So you can try salmeterol or you can try vilanterol. And it is worth trying that, but some patients just are really, really sensitive to all of that drug group. And sometimes then it's worth trying something different. So it's worth looking at, okay, so is it that you've got twitchy airways or is it that you've got inflammation? So is it worth adding in montelukast instead? And some patients just are really, really sensitive. I had one patient that I couldn't use a long-acting beta-2 agonist in at all because it gave her really bad palpitations and she couldn't tolerate them. And she ended up on a reasonable dose of inhaled steroid and some symptoms that we just couldn't get on top of, but I knew that her inflammation was under control and it was very difficult.
Okay, grand.
It's worth trying the other long-acting beta-2 agonists. So if it's the formoterol gives her palpitations, try one of the other ones, but just warn the patient that it might be that particular ingredient or it might be the drug group, but we'll try another one just to see what happens.
Yeah, okay, great. Right. Sorry, there's a few more coming in. Do you mind one more?
No, fine.
Then I promise we're done because there are two questions and they both seem to be related. This is from Lydia.
We have a question. It says, do you ever tell them to kick out their dog or husband?
So we got, is there any way of getting financial reimbursement for the test in primary care?
No.
And then Rao asked again, great session, very useful. Only obstacle is expense to practice and PCNs. Need some support from somewhere.
Yeah, so I think practice level is going to be very difficult. I think PCN level might be slightly easier. So there are a couple of things worth looking at. So diagnostic hubs is one option. The other thing is the Advanced Access Collaborative, which is an NHSE program, is looking at how they can get FeNO into primary care, and there will be some funding that comes with that. So that's coming out through the AHSNs, the Academic Health Science Networks, and they're also putting some education in with it. Now their timeline is different to the diagnostic hub timeline, which is a bit of a nuisance, but it might mean it comes, and they are looking at PCN level. So it's worth contacting your academic health science networks to ask what's happening about the FeNO Advanced Access Collaborative work, because I know the applications for funding for that will be within the next couple of weeks, I think. They were trying to get it out in December. I don't think they'll get it out until January, but it's worth contacting your academic health science networks because that's the way the funding's going. There'll also be some pathway transformation funding that could potentially be linked with that. And to be honest, once you've got it, the mouthpiece is, you can sort of get those under the radar almost. It's actually that initial outlay, but the price you've just quoted is hugely less. That most practices should be able to afford the price you've just quoted, because I'm used to paying a couple of thousand for the equipment I've had to use.
Yeah. Okay, grand. Well, yeah, Carol, thank you. You've been an absolute star, incredibly informative. Your time is greatly appreciated. For anyone that's listening, you'll be able to get in contact via email at a later date. We'll send out some mailers to either Intermedical or us, Bedfont, the manufacturers of the No Breath. This will be recorded. This has been recorded, so you'll be able to watch back again at a later date. So thank you everyone for your attendance, and have a nice evening.
Thank you.
Thank you.
Thank you.